The Ketogenic Diet for the Treatment of Type 2 Diabetes by Stephanie Bradshaw, Priscilla Alvarez, and Myra Guzman. Throughout this presentation, we will be going over the introduction and background of type 2 diabetes and ketogenic diets, our Pico question, the literature search that we did to find our original research articles, the evaluation of those articles, our concluding statements and grade, and then research limitations and future needs, as well as the recommendations for practice.
Type 2 diabetes. Type 2 is the most common form of diabetes. It's characterized by high levels of blood glucose, also insulin resistance. And listed here are some of the contributing factors. So we know that obesity plays a role, physical inactivity, family history, and then also ethnicity can also play a role. This diagram right here kind of explains the pathophysiology to diabetes a little bit clearly. So you can see up at the top we have those lifestyle factors plus your genetic predisposition. They're all leading to insulin resistance. So once insulin resistance occurs, there is some beta cell compensation that will occur. Eventually those beta cells are going to give out and lead to early failure with impaired glucose tolerance. As that continues to go on, you're going to see the beta cells go into complete failure, which is when diabetes occurs. And then that just is beta cell exhaustion. So at that point, the patient will have developed type 2 diabetes completely. The ketogenic diet is designed for a state of ketosis, and it's monitored by urine ketones and the serum beta hydroxybutyrate. Its most common form is in a ratio of 3:1 or 4:1. So that just means that 3 or 4 grams of fat for every 1 gram of protein and carbohydrate combined. It's a diet that's composed of a lot of meats, eggs, cheese, cream, butter, oils, nuts, high fats, and just very small amounts of fruits and vegetables. There are also modified ketogenic diets which are lower, so 2:1 or 1:1 ratios, that also have some benefits for people who cannot follow the diet, the full ketogenic diet completely.
Our Pico question is, can a ketogenic diet significantly reduce hemoglobin A1C, postprandial glucose, and fasting glucose in type 2 diabetic patients compared to a carbohydrate-controlled diet?
Listed here is our literature search strategy. So over to the left we have our inclusion criteria. We were searching for human studies with adults 18 years and older. All of our studies had to be within 10 years, focusing on type 2 diabetes rather than type 1. And we also searched for the ketogenic diet and carbohydrate controlled diets. Also, everything was in the English language, and we were looking for just any kind of clinical trials. So our exclusion criteria were animal studies, people less than 18 years old, or studies that were just greater than 10 years. Also type 1 diabetes and non-English studies.
Evaluation of research. The first article I will be reviewing is the evaluation of a simple policy for pre- and postprandial blood glucose self-monitoring in people with type 2 diabetes not on insulin. This article was written by K. Bonomo, A.D. Solve, E. Fioria et al., and reviewed by me, Stephanie Bradshaw. The purpose of this study was to evaluate the usefulness of a new self-monitoring blood glucose policy in diabetes clinics in Italy, which may provide clinically useful pre- and post-prandial blood glucose data. The design was a randomized control design, and like I just said, it was performed in Italy. The inclusion criteria for this study was you had to be a type 2 diabetic, not taking insulin, with an HbA1c value of 7% or greater. You had to be a current diabetes clinic patient, already participating in a self-monitoring blood glucose practice. And you can see right here, I actually got my letters transposed a little bit, so it's actually supposed to be SMBG for the abbreviation for self-monitoring blood glucose. The exclusion criteria for this study was you couldn't be a type 2 diabetic, you couldn't be on insulin. If you weren't a patient at the diabetes clinic, you were not eligible, and if you had a HbA1c level lower than 7%, or you were not currently practicing the SMBG, then you were not eligible for this study. The timing of the measurements for the self-monitoring blood glucose and HbA1c was measured at baseline, at 3 months, and at 6 months. Pre- and post-prandial blood glucose was monitored either once a month or biweekly during the length of the study, depending on which group you were in. So we had two treatment groups, the control, which was group A, and they were using the usual SMBG procedure, which was doing one time a month complete full blood glucose profile. So they did a one time a month, they checked their blood sugar for fasting 2 hours after breakfast, 2 hours after lunch, and 2 hours after dinner in one day. And then the intervention group, which was group B, had a more intensive SMBG procedure in which every 2 weeks they would complete the full blood glucose profile. So twice a month, basically, they would do a fasting, a 2 hour after breakfast, 2 hour after lunch, and 2 hour after dinner blood sugar check. So the reason that they kind of went with just the one time a month for the usual SMBG procedure was because in this region in Italy, they do give blood glucose testing strips to type 2 diabetic patients that do not take insulin. They do get free test strips, but they only get 4 test strips a month. So they really wanted to kind of mimic the real world setting in that aspect because they wanted to see if, cost effectiveness and like what these patients would actually be receiving could be applicable to having greater results. So the strengths of this study were that it was a randomized control design. They used real world settings. The type 2 diabetic patients were already familiar with the SMBG procedure, and at the diabetes clinic that they went to, they had the same diabetes team, the same education, and same treatment policies throughout the study. And then another strength of this study is that it provides results on pre- and postprandial blood glucose levels as well as HbA1c levels as results for the study. The limitations for the study are that it had poor compliance. The SMBG relevance wasn't emphasized to the participants in this study, so that it would remain more in a real world type setting opposed to a controlled trial type setting. And then the treatment groups were sized differently. I feel like this was a little bit of a limitation, but I don't know. The study seems to think that there was a little bit of an advantage for some reason. The study findings were that Group A at 73% was more compliant than Group B at 44%. Um, After 6 months, Group B had a significant HbA1c reduction of 0.25%, which was likely due to the larger sample size, but also in Group B, the non-compliant groups tended to have a higher BMI. The compliant Group B patients had a significant decrease of pre- and postprandial blood glucose concentrations, while compliant Group A had no change from baseline. In conclusion, when in compliance of the study protocol, a new 6-point SMBG profile performed every 2 weeks, there was a significant reduction in HbA1c levels, as well as a reduction in pre- and postprandial blood glucose concentrations. The overall rating for this study was neutral. The second study I evaluated was the effect of low-calorie versus low-carbohydrate ketogenic diet in type 2 diabetes. The article was written by T.A. Hussein et al. And reviewed by me, Stephanie Bradshaw. The purpose of this study was to evaluate the effects of administering a low-calorie diet, LCD, and a low-carbohydrate ketogenic diet, LCKD, for 24 weeks to improve glycemic control and decrease the need for diabetic medications in overweight and obese patients with type 2 diabetes. This was a non-randomized controlled trial, and the inclusion criteria was that you had to be an adult, 18 years or older, with a BMI greater than 25 and fasting serum glucose levels of greater than 125. The exclusion criteria was renal insufficiency, liver disease, unstable cardiovascular disease, which was determined by history, lab tests, and or a physical exam. And the timing of the measurements for this study was that every 2 weeks, the participants would return to the treatment facility for counseling on diet and medications. At baseline and at 24 weeks, anthropometric measurements were taken, and at weeks 0, 4, 8, 12, 16, 20, and 24, after an overnight fast, blood was drawn to get a complete blood count, lipid, renal, and liver profiles. Food records were also collected at 2, 18, 12, 16, 20, and 24 weeks. This study was a 2-by-2 design where there was 2 control groups, the non-diabetic LCD and then the non-diabetic LCKD were both control groups. And then the 2 intervention groups were the diabetic LCD and then the diabetic LCKD. So for the low-calorie diet, participants were given appropriate dietary guidelines and a calorie restriction of 2,200 calories per day, whereas the low-carbohydrate ketogenic diet, participants were given a handout about ketogenic diets and a list of allowed foods and then foods to avoid. They could eat unlimited meats. They were asked to eat up to 2 cups of salad a day and drink 6 to 8 glasses of water daily. There weren't a whole lot of restrictions in the diet. The only thing they really asked was that they avoided trans fats. There were not any strengths or limitations listed to this study. There were a lot of really great findings in this study. So, first thing was body weight, waist circumference, and BMI were positively significantly affected in all of the test groups with a p-value of 0.001. So that was highly significant. The effectiveness of reducing blood glucose levels in the LCKD diabetic group was greater than the LCD diabetic group, with another really high significance of the p-value being less than 0.001 again. And then both diabetic and non-diabetic LCKD groups had a significant decrease in total cholesterol, LDL, and triglycerides, and then also a significant increase in HDL cholesterol levels as well. There was a reduction noted in HbA1c levels, even though that wasn't something that was really being tested for this study. And then also there was greater glucose control that was observed in the low carbohydrate ketogenic diet with the diabetics as well. So in conclusion, the low carbohydrate ketogenic diet had a significant positive effect on weight, waist circumference, triglycerides, HDL cholesterol, and improved glycemic control, as well as HbA1c levels, even in short duration. There's still little research on ketogenic diets for the treatment of type 2 diabetes in place of medication, so it's recommended that further studies investigate this. However, under medical supervision, the LCKD can be effective in lowering pre- and postprandial blood glucose concentrations. And I didn't write it on here, but also possibly reducing the amount of medications needed to take as well. So this study received an overall rating of positive.
The title of this article is A Low Carbohydrate Ketogenic Diet to Treat Type 2 Diabetes. So the purpose of the study was to evaluate the effects of a low-carb ketogenic diet in type 2 diabetes patients, and it lasted for 16 weeks. The design was a single-arm pilot diet intervention trial, and listed here are just the inclusion and exclusion criteria. So pretty much they were looking for patients with type 2 diabetes, high BMI, and they either needed a high fasting glucose or a high HbA1c level without the use of medications. And they excluded anybody who had renal insufficiency, liver disease, unstated or cardiovascular disease, determined by history, physical exam, or lab test. So the timing of the measurements was a 4-day take-home records collected at baseline and weeks 2, 8, and 16. There are also biweekly measurements of anthropometrics and vital signs, urine ketones to confirm they were in ketosis, and they also measured the incidence of hypoglycemic episodes. So for this study, there was no control group. Basically, the subjects here were educated on the instructions for the low-calorie ketogenic diet, which they were provided with a handbook. They were also instructed to consume multivitamins and make sure they were drinking enough water. Physical activity was encouraged, and they received diet counseling and medication adjustments biweekly. So this study found that the fasting glucose decreased by 16%, and they also found that HbA1c decreased from 7.5 to 6.3, which they found was significant. And the conclusion was that the low carbohydrate ketogenic diet had positive effects on glycemic control and improvements in HbA1c. So listed here are just some of the strengths and limitations. Some of the limitations were that there was a small sample size, it was a short duration that only lasted 4 months, and there was no control group. Strengths listed here, just that it was in a real-world setting, so the patients bought all of their own food and prepared it at home, and also they were given that biweekly counseling and medication adjustment just to ensure that their health was not compromised during the trial. So this next study was titled A Non-Calorie Restricted Low Carbohydrate Diet is Effective as an Alternative Therapy for Patients with Type 2 Diabetes. So this study just wanted to examine the effects of non-calorie restricted low carb diet for people who could not adhere to calorie restricted diets. So the design was a randomized open-label trial. It included type 2 diabetes patients. HbA1c levels had to be between 6.9 and 8.4%, and the exclusion were just high protein urea, serum creatinine, and high AST or ALT that was greater than 3 times the normal limits. They also did not include patients who currently were in ketosis. So this was just solely looking at low carbohydrate versus calorie restricted. So for timing of the measurements, every 2 months, HbA1c levels were measured, as well as lab blood tests, body weight, and incidences of hypoglycemic episodes. They also did diet assessments in the form of 3-day food recalls before the visits to measure their HbA1c. For the intervention group, they followed a non-calorie restricted diet, which had between 70 and 130 grams carbohydrate a day. They instructed them to try to stay within 20 to 40 grams per meal to prevent postprandial hyperglycemia. And also they were allowed to consume 5 grams of carbohydrate of sweets 2 times a day. So the control group was just calorie restricted, and the way that they based their calorie intake for the day was just ideal body weight times 25 calories, kcals. And listed here are just the macronutrient targets that they gave them. So carbohydrates between 50 and 60, protein was 1 to 1.2 grams a day per kilogram, and then fat was less than 25%. Okay, so the study findings here were that the low carbohydrate group had significantly lower HbA1c levels compared to the calorie restricted. There were no changes in, there were changes, but there were similar changes in fasting plasma levels, but they were not significant in both groups from baseline to the end. So in conclusion, a non-calorie restricted low carbohydrate diet are effective in lowering HbA1c levels in type 2 diabetes patients. So listed here are the strengths and limitations. This was also a small study. It was short duration. This one was a little bit longer, 6 months. And there were no other dietary assessment methods used. So strengths were that it was a randomized trial and that the subjects received that diet counseling every 2 months. Conclusion statements and grade. So to answer our question, can a ketogenic diet significantly reduce hemoglobin A1c, postprandial glucose, fasting glucose in type 2 diabetic patients compared to a carbohydrate-controlled diet? Our current data appears promising as our findings show reduction in both pre- and postprandial blood glucose levels, as well as significant reductions in HbA1c. So one study did report HbA1c reductions with the low-carb intake. Their findings were it was 6.1 plus or minus 0.4% at baseline to 7.0 plus or minus 0.7% at 6 months. Though it showed improvement, it was not as significant as the ketogenic diet results. So for example, one of our studies showed HbA1c levels at baseline of 7.5 plus or minus 1.4% and 6.3 plus or minus 1% at 4 months. So you can see the difference there. It was greater with the ketogenic diet. Overall, we gave the grade of fair 2.
Recommendations for practice. With a fair rating, the recommendation of using the ketogenic diet as a dietary measure in the treatment of type 2 diabetes should be proceed with caution. In reviewing the evidence presented, the effectiveness of a ketogenic diet on HbA1c levels, fasting glucose levels, and postprandial glucose levels, it has been shown to be effective in the treatment of type 2 diabetes. However, it is recommended that if a patient has any type of liver or kidney disease, as well as cardiovascular complications, that another type of diet be advised. Under strict supervision in obese populations, the LCKD is safe to use for a longer period of time as it has shown to have greater effects on controlling blood glucose levels and reducing HbA1c levels in the obese. And this concludes our presentation. Here are our references. If you have any questions, please ask them below. Thank you so much for listening.